Okay, so that's 5 o'clock. It seems to be a number of people in already. So again, welcome everybody and thank you so much for joining us for the third webinar in this series on access to patient health records. My name's Emma Doball and I'm one of the patient editors at the BMJ. And our webinar today is going to be looking at health inequalities and particularly looking at how to ensure granting patients access to their records doesn't exacerbate any of these. We're going to start off today with a 10-minute presentation from one of our speakers, and then we will be opening up for a panel discussion with our panelists. As we kind of are having our discussion and during the presentation, please use our functions on Zoom to communicate with us. So we have both of our chat box, which you'll be able to find on your screen. Please do use this to put any thoughts, comments, share your own insights or experiences about patient access to records. And we love seeing these discussions being so lively in the previous 2 webinars. There's also our Q&A box, which you can use to pose any questions in particular to our panelists and to our presenter. I will do my best to get to as many of these as possible during our discussion, and we'll try and at least cover some of the main topics in particular that you are all interested to know about from our presenters today. So today I'm going to kick off our session with our presentation from the wonderful Dr. Anshu Abhat, who's joined us today. Welcome, Anshu. It's lovely to have you here. So Anshu, MD and MPH, is the Director of Patient Engagement at the Los Angeles County Department for Health Services, an Assistant Professor at UCLA David Geffen School of Medicine. At LA Health Services, she directs patient engagement and outreach for LA services with 500,000 empaneled primary care patients across 4 hospitals and 25 multi-specialty clinics. Recently, she's led a system-wide patient engagement and outreach work around COVID-19, COVID vaccinations, and primary care quality. Dr. Abhat's research focuses on use of digital tools in safety net populations with particular interest in populations with limited English proficiency. She's interested in studying, developing, and implementing best practices to promote digital health equity. She was a California Healthcare Foundation Leadership Fellow. She's multilingual, originally from Mumbai in India and grew up in Los Angeles, a graduate of the University of California, San Diego for undergraduate and medical school and the Harvard T.H. Chan School of Public Health. She's completed her internal medicine residency training at the University of Washington in Seattle. So over to you, Anshu.
Thank you so much for that very kind introduction. I'm just going to pull up some slides here to start our discussion. So for today, to get us started, I'm going to talk a little bit about OpenNotes and beyond and talk about digital health equity in the Los Angeles safety net. And that will be a frame for our discussion with our panelists later on as well. So I don't have any financial disclosures. And the agenda of what we're going to cover today is a little bit about LA Health Services. Who are we? What is our organization like? What was our approach to OpenNotes, which started in 2018? What do we need to know about patient portal adoption in the safety net? And that is very relevant as we have this discussion about notes and data. And then what are our approaches to improving digital patient engagement for county health systems? So one piece to kind of start and frame the discussion is this piece around equality versus equity. And this group on the webinar has been talking about this, what is equality and what is equity? So is it providing the same resources for different people with different needs, or is it providing individual resources that are specific to the needs of those so that they can have a more equitable experience? So we can talk a little bit more about that as well. And a lot of different images that will be thrown out here. This is just one in particular that I like. So what is LA Health Services? So, we are a safety net organization. We have about 25 multi-specialty health centers, which provide primary and specialty care. We take care of about 500,000 primary care patients in Los Angeles County. And we're mostly managed Medi-Cal and uninsured patients. Those are the majority of the patients that we serve. And I'll talk a little bit about Medi-Cal and Medicaid. So we have 4 acute care hospitals, and just for reference, our health record vendor is Cerner, which some of you may use as well. And just my practice, I'm working in the primary care clinic setting, so somewhat of a GP, a little bit different context, and also a bit in the hospital, rounding on the wards with resident physicians who are training. For Medi-Cal and Medicaid, we have a US public health insurance program for people with low income, which expanded under Obamacare to 133% of the federal poverty line. It's a federal state partnership and funded as such, and it covers 80 million Americans now. So it's a huge expansion from what Medicaid was previously. So what has our journey been with patient portals? So, one piece of context is that any one of my patients can sign up for the patient portal. And in that patient portal, which is a website that connects to the electronic health record, they can access almost all of their health information. So we launched our patient portal with our new electronic health record in March 2015. And that's similar for, I think, a lot of US-based health systems. And then legislation kind of moves some of those things along. So messaging, which means that you could message your doctor and your doctor could message you back, or your care team could message you back, started in June 2016. Then we began to release radiology results, and patients could self-enroll in the portal. They didn't need an email invitation to enroll in the portal in March 2017. And then we kind of took the big bite where we said, we are going to do OpenNotes. And this was before federal mandate. And so this was January through April 2018. Took a lot of engagement with our providers, specialty care and primary care providers, but we fully launched all of our provider notes to be available January through April 2018. I'll talk about some of the exceptions as well. And then we also launched eClipboard, which is online forms that patients can fill out, and self-scheduling in about November to January 2020 to 2021. And actually, we have a bunch of new changes coming in a few days. We're launching a new app and such. And with the OpenNotes piece, because I know that's been relevant for this audience, we initially launched with a 3-day delay from when a trainee signed a note. We have a large trainee system within our health system, and that gave some time for attending physicians or consultants to review and addend those trainee notes. We are not releasing behavioral health notes. There are some particular provisions around that in our health system and within kind of the national context. So things like therapy notes, psychiatry notes, social work notes, we're still kind of working on that piece of things. So that's just a little bit of the context for us. I will admit that I started sharing notes in around 2014 with the initial OpenNotes work done at Harborview Medical Center in Seattle. So I had some experience with it, really liked it, and then brought that to our health system. So, what happened after launching OpenNotes in 2018? I think that's the question that most often gets asked. And I think the concern is that the sky is going to fall. And I just want to validate that that's a normal concern to have, because it's a big cultural change. But what I found at Harborview and also in LA Health Services is there were really no notable changes in workload or workflow. There were some initial patient concerns around not being aware of the diagnosis that was documented. One that came up in particular was around neurology and psychogenic seizures, some initial provider questions and concerns, but ultimately not too much actually. And then just so you get a sense, 3 out of 10 of my clinic patients that I see in my general clinic are reading their notes. So if you kind of estimate the page views and stuff, and it gives you a sense of how many patients are accessing those notes. And then there was the 21st Century Cures Act. So that was new in the US, which really mandated the release of all data and notes. And there was a lot of variability of who was sharing what and how were they sharing it and how quickly were they sharing it. So we moved everything to immediate release. We had already moved labs in that direction, but we moved notes and radiology to immediate release for that April 5th change. We also started to release some of the inpatient notes, which sometimes are, full of some copy and paste, some jargon, but we actually started releasing all of those. Again, not releasing the behavioral health notes. And we're working on opening up adolescent portal access for age 13 to 17. We have some particular issues in the state of California that we need to keep in mind for adolescent access. And I think the main piece that I have been taking away over the last couple of years is that, patient engagement is no longer a standalone issue aside from how we deliver healthcare. It really is a critical building block to improving healthcare in the safety net and with vulnerable populations. So, when we talk about things like notes and data and access, they really aren't possible without patient portals. So the question is, who is likely to access patient portals? And as we know, our vulnerable populations are less likely to access patient portals. Just so you get a sense here on the right, the change in the number of patients accessing their patient portals in the US has increased dramatically. So in 2014, about 27%. Now we're almost about 40% of patients that are accessing their patient portals. But racial and ethnic minorities, older patients, those with lower socioeconomic status are less likely to access those patient portals. So what are we doing about it? So we had done some initial research, some focus groups with our patients who also we have a group that's largely limited English proficient, Spanish speaking as we're in Los Angeles. And, our patients said, we need more education, we need more support, we need more resources, we need to understand these tools, and we want to understand these tools. So our strategy has been to implement programs that teach our patients how to navigate their patient portals and help them better understand that important information contained in their records. And we know that that's an effective strategy in patients and populations with lower health literacy who have less comfort with technology. We've also really been identifying who's the care team and who's the care partner. And that's been a request of our patients through some of our patient family advisory councils, where they are giving us information and co-designing some of these processes with us. So for caregiver and family support. So for example, an older patient might rely on their child to be their proxy to access that information and help them navigate their care. We offer all patients access. And I think this is actually something that gets missed and that we're continuing to work on. There is probably some implicit bias in who gets access, who gets offered access. And so we're really trying to work on that and make sure that that's equitable. And then we do ask our providers to pitch and reinforce the use of the portal, as our patients are often relying on their providers for that recommendation. And the challenge is that resources to evaluate digital health literacy and to educate our patients. So these are some of the challenges that we've faced around patient portal enrollment in the safety net, which then again connects to the access of information. Design, again, IT products are not usually designed equitably. I think that has been a big takeaway for us, and we continue to work with our vendor on that, but it is really challenging. Digital health literacy, language is a whole new ballgame, and usually not approached as naturally as we would like to have it. Internet access, equipment access, privacy concerns, and materials and communication so that patients know what's going on. So now I'm just going to present a bit of a framework for our county health system here in Los Angeles County. How are we approaching our digital engagement? So, at the patient level, we have these patient family advisory councils that meet monthly, and we now regularly run everything new that's coming, not before we design it, but in this co-design process. And we're regularly soliciting and incorporating patient feedback in many areas, but especially related to technology. In the health system level, we've just launched a new program called the Health Tech Navigator program, or Community Health Worker program, for in-person patient support at clinical sites. This is something that we get asked, all the time. It's really that in-person support that we know at our health system that we need. Very hard to sustain and resource, but we are starting that process. We're also working with our providers and staff to get their feedback, because it's really a two-way street with engagement. Can't do patient engagement without provider and staff engagement. We're doing a lot of performance improvement work around enrollment and utilization of the portal, and we continue to advocate for improvements with our electronic health record vendor and design. And then the community, we're starting to develop more community partnerships to promote education and digital health literacy among community members, so that it's not just the health system, which often is pretty resource constrained, but we're better using our relationships with community partners to educate our communities and our patients. And then at the county and policy level, there is a digital divide strategic plan that's happening in Los Angeles County. A lot of that is focusing on increasing broadband access and increasing device and cellular access. So that's really been our approach in Los Angeles County. We're very proud of this Health Tech Navigator program that we're launching that will help our patients learn how to join video visits, conduct e-visits, self-schedule their urgent care appointments, things like that. And I'm happy to talk more about that as well. And that's really just to kick us off and get started our discussion. Thank you so much.
Thank you so much, Anshul. That was a really great presentation, a really good overview of the topic and the area. I just want to start off by opening our discussion now, and I'm just going to introduce our panelists here we have to join us. So first up, we have Christine Sorensen, who's PhD and is the founder of the Global Health Literacy Academy, president of the International Health Literacy Association, and executive chair of the Health Literacy Europe. She's a super trends expert and a member of the European Health Futures Forum. Christine is also a visiting lecturer at the Belleville University, Germany, the MCI School of Management in Innsbruck, Austria, and the Centre for European Studies at Maastricht University in the Netherlands. And her educational background is in medicine, public health, and global health diplomacy. Next up, we have Ray Jones. Ray Jones is a professor of health informatics and a researcher in e-health and co-director of the Centre for Health Technology at the University of Plymouth. He started his career in digital health at Nottingham University, where in 1979 he set up the Nottingham Diabetes System, which issued the same computer-printed summary of the record for the hospital, GP, and the patient. He moved to Glasgow University in 1984 and over his 17 years there, developed and evaluated touchscreen kiosks and carried out a series of randomized control trials in which patients had touchscreen access to their records. He moved to Plymouth in 2002, where he leads a number of projects, always trying to ensure that they consider digital health equity. Ray was awarded an MBE in 2021 for his services to digital health. And finally, but in certainly no means least, we have Amir Hanan. Amir is a full-time GP at Houghton Thornley Medical Centre in Hyde in the UK and is a passionate advocate for developing a partnership of trust between patients and clinician. He's a director of the local GP Federation Orbit Healthcare Limited, chair of the West Pennine Local Medical Committee, chair of the Association of Greater Manchester Local Medical Committees, co-chair of the Greater Manchester NHS Values Group and the chair of the World Health Innovation Summit. Amir was also awarded an MBE in the New Year's Honours list this year. So welcome to all of our panelists, and I really invite all of our attendees here to post any questions, comments, anything in our chat and Q&A functions today. We really want this to be an interactive session. So I wanted to kick off our discussion there by just touching upon some of the points from Anshul's presentation, and particularly around when we're talking about health equity, who are the groups that we really need to be thinking about when we're talking about this? And Christine, I'm going to start with you and get your thoughts on that.
Thank you so much. Well, you can really ask the question, what's the point of getting access if you don't understand it? And understand the information. And we know from our health literacy research that in Europe, for example, almost 1 in 2 have difficulties in accessing and understanding health information. And in US, it's about 9 out of 10 that have difficulties. So we need a new, I would say, universal approach. So it's great that everyone is getting access to their own information, but we need to find a way where it is useful for all the partners in the journey towards recovery. And we know that the groups that are particularly vulnerable, it was also mentioned in the presentation, that's often elderly, it's people with lower education, people with low income, some from different migrant groups, for example, different ethnicities, where English or any other language may not be their first language, and that makes it difficult. So we want to make our system people-centered. Many systems have chosen to have a patient platform where it's made easier to understand, and I think that's the way forward. Thank you.
Thank you, Kristen, really helpful. Amir, I'm going to come to you next. Anybody to add to that list of people we need to be thinking about in more detail?
Well, if I speak about the UK, and this is the latest data from the Office for National Statistics, it's very interesting. 92% of all adults in the UK were recent internet users in 2020. That's up from 91% in 2019. Almost all adults aged 16 to 44 in the UK were recent internet users. That's 99% of the population, compared with 54% of those adults aged 75 years and over. But even if you look at the 75 and over group, that's nearly doubled from 2013, when it's 29%, up to 54% in 2020. There's only 6.3% of adults in the UK that have never used the internet. That's down from 7.5%. And if we take disabled adults, then it's now 81% of all disabled adults have access to the internet. That's almost 11 million people. London continues to be the UK region with the highest recent internet use, and that's 95% of the population in London, whilst Northern Ireland remains the lowest at 88%. What we're really talking about is that essentially the internet is profoundly available and accessible to almost everybody, besides perhaps that group over 75 years of age. And later we can talk a little bit more about what I've been doing in the practice around that. But really anyone below 45 years of age, every single one of them got access to the internet and really should be able to do the kind of things that, that my patients enjoy.
Thanks, Amir. Really helpful to have some of the data there from the UK as well. Ray, any thoughts on that?
Well, I was just wondering if I could just go back briefly to just check that everybody we use the terminology right all the way through, because actually the heading of this this webinar was about health inequalities. It wasn't so I mean really we've got health inequalities, we've got digital equity and digital health equity, and Anshu has sort of really sort of talked about it already, but I just thought it was worth going back to, because I mean health inequalities of course is the big ogre in the room, and in a way digital health equity is just a sort of little pimple on that big ogre, because you know we know that these wider determinants of health and poverty and education and economics is really responsible for most of the health inequalities. But if we can improve digital health equity, then of course we should, because that's every little helps. And if I can just go back to sort of picking up on some of the things that Anshu was talking about, and talk about some of them in the Southwest. I mean, some of the ideas are much the same. So the navigators that Anshu was talking about in the Southwest, we've been trying to get what we're calling digital health champions. We're trying to get nursing students to help either small communities or families to make better use of digital health. And the design issues are really crucial. So again, in the Southwest, we're trying to work with companies, digital companies, to do that co-design process. Again, very important, because so much of the it's not just software, but also devices and all sorts of things don't really allow for naive users or people who've got any sort of sensory impairment. So just thought I'd want to pick up on those two things.
Thanks, Ray. Yeah, really important point. And actually, Anshu, we have some questions here in the chat from a number of people about these patient navigators. So just sort of questions around who are they? Do they get any training, any support? So I just wondered if you could touch upon that.
Yeah, so I've tried the Navigator function in many forms because I think this is we hear it over and over again, especially with vulnerable populations, that there is a desire to become more confident in using these tools. And sometimes some of our patients feel very intimidated by some of these tools. And I will say there were some questions again around design. I think design is a key part of why some of these tools are challenging to use. So we tried volunteers a couple years ago. It's just very hard to get a standard. Volunteers come and go, and trying to get them to regularly work with our patients, it just didn't quite work. I did a pilot project with a group of students so we could prototype our Now Health Tech Navigators program this summer, and that was very successful. And so what we decided is we really had to hire community health workers and we had to train them. And that's actually what we're doing right now is they're undergoing a very intensive training process. They learn to navigate on the phone and in person so that, let's say it's a little slow in the clinic, they can actually do a lot of phone navigation. We may eventually do some video navigation as well, but a lot of our patients like using the phone. So we have a formal, program where we have hired these folks. They tend to be young. So they tend to be young and bilingual. So English and Spanish speaking in Los Angeles for the most part, so that they can help our patients in clinic with the navigation. And we're trained them for about 2 weeks actually, and then do some testing with them. We're putting them in the clinics then, and then we're getting feedback from them as they engage with patients in the clinic. There's a lot of troubleshooting that they come up with too, because these IT products are not perfect by any means. So that's a little bit of what the navigation program looks like. There's also a piece of it where they learn about these pieces around equity and digital equity. And they're coming in with a lot of that background as well. Some of them are pre-health students, like pre-nursing, pre-social work, pre-med. And a lot of them have spent a lot of time in the community doing this, maybe practically in their own lives with their family members. So that's a little bit about the Navigator program.
Thanks, Andrew. That's really helpful. Amir, I wanted to come to you on this because I know we've talked about identifying in a family that one person who's the kind of gatekeeper of health. I wondered if you had some comments on that.
Yeah, so I'm going to give you a real life example of a real patient, and it kind of brings it all together and some of the things that I'm doing. So I spoke to the wife of an elderly patient of ours, and he's about 90 years of age, so above that 75 age group. And she was asking about something to do with her medications and repeat medications for her husband. So she's caring for her husband, which again brings another level of complexity, if you like. And along the conversations, obviously at the moment we're in the middle of a pandemic. There are huge pressures on us in primary care. It's difficult for people to get appointments. Winter is coming, and she was concerned about if he gets a chest infection, how's he going to access the surgery? How's he going to get an appointment? How is he going to get his medications and so on? So that was the challenge. So I asked her, I said, do you have access to the internet? And she said, no, I've not. I've just got a very simple mobile phone, and that's all I have. And I don't have broadband. She sort of kept saying she didn't have broadband. So then I said, okay, well, do you have any family? Do you have any children or grandchildren? No, I don't have any children. I don't have any grandchildren. So quite a challenge. And there is a small group of people that we recognize for whom, unfortunately, they're not going to be able to access the internet. And of course, as a GP, my primary role is to ensure that I give equitable access to all my patients, whether they have digital access or not. So then I said, well, would you consider buying one of these more modern mobile phones? It doesn't need to be the latest and greatest. It might be a hand-me-down from somebody else. Would you consider it? And she sort of said, well, I wouldn't really know how to sort of deal with it. So I then turned around and said, well, if you can get yourself a mobile phone that has access on the internet on it, then you can come down to the surgery and see me face to face. And that's another myth out there that GPs are not seeing patients. You can see I'm in my consulting room seeing patients. I've got my couch back there, and obviously I've got the internet and the computers and stuff. So take away that pain barrier, that feeling of I don't know how to use the internet. And I said, well, would you like to do that? And she said, well, actually, I do Google. So I said, oh, you do Google? How do you do that? And she said, well, I've got a tablet. I said, really? So I've got a tablet. I don't have broadband, but I have Wi-Fi. And I thought that was really interesting that she thought there was a difference between broadband and Wi-Fi. Of course, what I then knew is that she had a device and she was on the internet, but she didn't realize that. So then I said, well, can you bring your device with you? So she brought a device with her. I said, make sure you charge it up, because I've known people to bring a device, it's not being charged. So she charged it up. And then I said, bring the device and I will set the whole thing up with you. And not just for you, but also for your husband, so that you are not worrying about how to order prescriptions. And I'll even show you how to get an appointment by going online using the forms that Anshi was talking about, a similar kind of process. We use something called Engage Consult for getting appointments. And so she brought the tablet in. I then consented, and I went through a 2-minute questionnaire with her around what the benefits and what the disbenefits were, and I'll put that into the chat in a moment. Having then done that, I then downloaded the app onto her tablet, installed it. I registered all the PIN numbers and everything else that would normally need to happen. And that took about 15 minutes. And I remember her saying, gosh, Dr. Hannon, I would not have been able to do this. So I took all that pain away from her. And then I put 3 buttons on her tablet. One was for her to view her records and order repeat prescriptions. The second was how to book an appointment for herself and also for her husband. And the third one was the practice website. And I'll see if I could show you. So I'm just going to take my camera and see if I can turn it around so you can actually see. So that's the screen that I'm looking at the moment, which would normally have my clinical system. But over here, I don't know if you can see, but that's the practice website, and it sits right next to me. And the patient is sitting over here normally, so that when they're talking with each other, they can see both screens. And actually we know that when you talk about changing behaviors for patients, then the most powerful place is the consulting room, where a brief conversation by the doctor will encourage that patient to then go and make changes, whether that stop smoking, reduce alcohol, lose weight, or whatever it might be. So how about the doctor sort of showing the patient on the website what's going on, or on their smartphone what's going on, and introduce them to what there is. And then they can then go out and they can talk to the care navigators, everybody else. But you've planted the seed, you've created the interest. And for me, what's been really important is take that fear away of, because she didn't even know that she had, in fact, she said to me, she said, I don't have an email address. But the fact that she had a Galaxy tablet meant by definition, she must have had an email address. So I was able to show her that. And the really nice thing was after she did that and she had to go at ordering a repeat prescription herself, she then, as she finished, because I did my medical bit, she said, so Dr. Hannon, how do I check my emails? So I ended up showing a Google Mail app and showing her how to do that. It's about taking an interest. It's about recognizing the assets that the patient has. And that asset is the desire to want to learn and to help. She wanted to care for her husband as best as she could, taking all that other pain away and saying, I'm going to be with you. I'm going to journey with you. If you have a problem, come back to us, because we're an organization that listens. We're an organization that cares, and we're going to be with you all the way as we go through winter.
Amazing. Thank you so much, Amir. I think it's really helpful to have these kind of actual examples of what's happening out there, and showing ways in which that this can be delivered in a way to groups that I think many people, I think particularly older people, there's a number of comments and questions here saying, with concern about how do we, ensure that we don't allow access and patient access to records to kind of run away, and that people, elderly people or older people, are left behind. And I think there's a really important kind of point here from Joe Bailey around how do we ensure that older person also remains kind of involved and has some autonomy over their care, particularly if we're talking about things like having these health champions and health communicators as part of the kind of whole consultation. So it's really helpful to get your thoughts. Amir, Ray, do you have any thoughts on this area?
Well, I mean, apart from the digital health champion, I think in the end, the two things are digital health champions, digital health carers. I think so. I mean, a bit like Amir's example in a way is finding the key person within the family to make sure that they can do that, and that may be sort of the like me, the 70-year-old looking after the 96-year-old mother. So, and of course the cohort's going to move through. So in 10-15 years time, probably everybody will be using the internet, and what we need to do is make sure that the design is right. So we'll be moving more to voice interfaces and things like that. So I'm hoping that in 5-10 years time, I'm going to be able to talk to my box in the corner and say, hey computer, have I got my blood tests back yet, and are they in range, and what does that mean? So one of the advantages in terms of patient access to records, I think that at the moment we were talking about sort of the difficulties and the people who aren't there, but I think we need to talk about what the benefits of patient access to the records will mean for those people who may be struggling with the health literacy. So Anshia was talking about that earlier on, that many people will struggle with the terminology, will struggle to understand the information. And there's so much information out there at the moment that one of the advantages that we should be working towards is to use the medical record as a filter and as a way of tailoring the information to me, the individual. So and that's what we did. We were doing that 20 years ago. Okay, it wasn't sort of in the routine way that it's being doing now is in trials, but we took the medical record and we used the medical record as like the gateway to the rest of the health information. So we gave cancer patients, there was a randomized controlled trial, cancer patients who had access to their information indexed through their medical record were able to sort of click on the keywords and go through and gradually find out information, but starting from their medical record, so that the information they got was relevant and filtered, as opposed to patients who were given the best quality standard information. And those patients who had it via their medical record were much more likely to use the information. They were more likely to share it with their family. They were less likely to be anxious than the people with general information. So, we can look forward, I think, to using the medical record as a way of making that access to health information easier for those people who've got lower health literacy. So, there are some positives, I think, out of patient access to records.
Yeah, definitely. Thank you, Ray. And there's a number of comments and questions here, particularly around resources. And Anshu, I just wondered if you had any examples or anything for resources, both for patients to kind of give them the information and the guidance that they needed to get online, but also for healthcare professionals to think about how they're dealing with this and rolling this out. Any kind of thoughts from your experience?
Yeah, I mean, I think on the OpenNotes piece, the OpenNotes website, my OpenNotes website is a great place to start. On the other piece, I mean, we have had to develop a lot of local resources, both for patients and for staff. So for example, we're actually in like 5 days launching our new virtual healthcare platform and program, which embeds in a lot of this work that we're already doing. We'll include video visits and e-visits and some additional self-scheduling, things like that. But we develop a patient guide for every patient function. So we have a written guide, and we're also developing video guides because we know what we continually also hear is that people want, both our staff want video-based training in small sound bites, and our patients want video-based training. It's a lot of work to develop video-based training. So on the patient side, we actually have a group of students, undergraduate students, who have already done like maybe 30 scripts in English and Spanish, and some of those students are bilingual as well, who are actually going to do all these little mini videos so that they're embedded within the function of the portal. But it's a big, effort to do that. And then we have done that for the staff as well, because it's so hard to train people. I mean, you all know, we all have such different schedules. We're seeing patients at different times. And so to have video-based training that gives our staff the key points. What is this new LA Health portal that we're launching on November 30th? What do you need to know about it? What's your patient going to ask you about it? What are they going to ask your front desk staff about? What's the new app? How do you download it? These things we have to provide to our staff as well. So we have basically a series of staff job aids and video tutorials, and then patient job aids and video tutorials. And we're continually building out that library, but that's our approach right now.
Amazing. Thank you so much, Anshu. Amir, I'm just noticing your comment there around this topic and resources, and but also just who's paying for this. And I just wondered if you wanted to come in on that.
Yeah, so in our practice, I mean, I started giving patients full access to the medical records 17 years ago, back in 2004. And for me, it was part of building trust with our patients, but also part of shared decision-making process, a shared decision-making process. The way I would describe it, if you like, is that if I was employing a doctor to come and work as a locum in my surgery, and I said to that doctor that I'm only going to give you your problems list, your medications and your allergies, and get on and treat the patients. Oh, and by the way, if you get anything wrong, then they're going to sue the pants off you. That doctor will never come back to work here again, and he'd probably, and I expect him to go and report that practice to the authorities to say what kind of practice are they running. And yet, when we think about patients with long-term conditions, such as diabetes, COPD, heart disease and things, we expect them to, one, remember everything we've told them, even though we know that survey after survey shows that patients will only remember about 10% of what's been said, and that's straight after they come out of the consulting room or 3 bits of information. We expect them to know everything, we expect them to do everything. We expect them to manage their diabetes care, but we don't give them all their information to help them understand it. It's not just the data. And people talk about give us our data. Data without information to help them understand that data, it does not create knowledge. So if you're going to give them data, we need to give them information to help them understand that. And I find that within that 10-minute consultation that I have with the patient, where they might come with a whole multitude of problems, I'm reducing it down to what I think, or what we, I should say, think are the common issues, what our common agreed goals are, what we're going to try and do to try and change things. And we write those things down in the consultation so that in effect, that becomes the care plan that the patient can then go away and read. They can share it with their family, with their loved ones or people they trust or whoever's caring for them, so that they can follow that through. And I think that's the kind of medicine that I wanted to practice 16 years ago. And it didn't make sense to me to only share part of that record. So unlike Anushka, from day one, we gave our patients full access to the whole medical record, including our children, including people with what I would call primary care mental illness, not secondary care mental illness. And there were some groups, and because it was a consent process, those people that couldn't give consent. So I noticed people saying, what about patients with dementia? Well, they're different because they can't give consent. But what about the 99% of the population that hasn't got dementia, that can consent for things, that does have the choices about who they marry and what education they have and what job they do? What about activating that group of people? So I went along on that journey, and currently at the moment, just to give you some of the figures that we've got, overall we've got 13,000 patients, and 81% of them have got full access to the medical records, but 100% of all our pregnant women, 97% of our type 1 diabetics, those are the insulin dependent diabetics, Bengali patients, we've got a large Bengali population, it's 81% of the population, but it's 89% if you are Bengali. That was never what I was expecting. When I first started, not one of them came in asking for access to their records, but they did come in saying, I'm worried about my diabetes, I'm worried about my COPD, I've got high blood pressure. And so as part of my management, it would be about explaining what that condition was, starting them on medication, referring them to the hospital where needed, and also saying, have you got a smartphone? Have you thought about getting a smartphone? I'd like to help you so that you can read what the doctor or nurse has written. If you don't speak English, is there someone else? Is there a child? Is there a grandchild that could help you? If you're flying off to Bangladesh and you're at risk of having a stroke or whatever it might be, I would bend over backwards to try and help them to make sure that as they got onto the plane, they knew how to access their records. If they fall ill out there, they can do that. Those are the kinds of things that we were doing, hoping that as a consequence of that, they'll get better care and hopefully they might live longer and we can start to reduce the health inequalities.
Thanks, Amir. So many interesting and important points in there. Christine, I'm going to come to you next in particular.
Yes, thank you very much. I think we have to face that the health records was a communication means to be used between doctors. So they are taught to write their messages into the language used in health records. And I think it will take several generations to change that language or find ways to make the language much more clear, because you're trained at it in medical school to write very short, concise, using Latin concepts and so on. So either there is one very short, concise version to be shared with other professionals, or we try to write in a new language everyone can understand. And I think that takes a system approach to change that. Otherwise, it will take generations of doctors to focus, and it means that it's not really to blame the patients in any ways. It's really about obsession with health records. Thanks.
Thanks, Christine. Yeah, Ray, can I come to you around this, around kind of how do we educate and train and support the kind of next generation of doctors in this?
Well, I noticed that there were one or two comments in the chat about this. I mean, we clearly need to have this topic should be, and digital health in general should be in the curricula of the medical school, nursing, all the allied health professions, it hasn't. It's been a bit. That's been a bit patchy in the UK at least as well. You know, some universities have been doing it better than others. Of course, being brilliant at it, but no, not really. It does need to be in there, and we need to bring. I think a lot of universities do bring patients in either virtually or in reality as well, so that their viewpoints are brought into the education of the students. So that's really important. But one of the problems, I think, is the bodies who determine to some degree what the curricula is. So I think the GMC has probably been better. I think the Nursing and Midwifery Council, I think, could well pull its socks up in terms of bringing digital health into the curricula. Allied health professions, I think, has been probably better than some. So we do need to be in there, and it needs to come partly top down from the professional organizations. They should require it of all universities to make sure that the use of digital health, public health, and the understanding of equity and the issues that we're talking about today need to be in there. And it needs to be sort of clearly just a requirement, not just as an add-on, which it sometimes is.
Yeah, Christine, I wanted to come back to you actually on that point around schools and it not being an add-on. Do you want to add to that?
Yeah, I saw in the chat that Tessa Richards was mentioning the role of education from a very early age, and I fully support this. I think we need to also not only rethinking the health systems, but also rethinking our educational systems. How do we really want to improve not only being able to take care of ourselves, but to improve health in the first place and well-being as well? And that would, I think, have we will need to build on a new topic called health and well-being. And it should not be an add-on to anything. It should be a new topic, like we have geography, biology, math, and languages, and so on. Why not health and well-being? Most school systems have it as an add-on at this stage, and it just makes it really random which teachers are teaching it and at what time and so forth. So let's really invest in well-being societies. We want to invest in well-being economies, which means that the focus should not only be on fix and repair, but really on improving people's life and quality of life, and therefore also health and well-being as a means to quality of life. And that takes a full, the full scale transformation. Thanks.
Yeah, absolutely. I think for me, again, this raises the issue as well. It's not just about the individuals. I think often when we talk about this, we talk about patients and then we talk about healthcare professionals, but there's also the systems, and how do we, I was wondering if we could have a bit of a chat about what's all of your thoughts on how we allow our healthcare systems or improve our systems to allow this to happen in a way that's equitable, as we've mentioned from the start. So Anshu, I was going to come to you first and get your thoughts on how do we do this?
Yes, could you frame the question one more time, because I was answering the chat.
Yeah, of course. Too many things going on at once. So I'm just saying, in terms of we often talk about health inequalities, we talk about the individual people. So how do we ensure that the systems are allowing this to be dealt with in the best way?
So, and this may be a little unpopular, but and the co-panelists have heard this. I mean, I think policy is a huge part of this, because what I'm seeing in the chat is that there is so much variability in the UK of who has access to their records. You have someone like Dr. Hanan, who has gone above and beyond and actually has done a lot of the things I would love to do in his practice, but that a lot of GPs and others don't feel empowered to be able to do that for their physicians, for their patients. They may not have that time. at the same time, I think we've also had this discussion that you can't just put policy out there and expect everybody to adapt around it. You have to have an evidence base, you have to have a training program, you have to have comfort, because we are the ones, the physicians and staff and nurses, that are going to answer questions. So we also need to feel comfortable, confident, and to some degree on board with some of these changes. But I think if it's very piecemeal, that's not equity. I mean, if you're giving one particular population access, even though it may be in a vulnerable area, that's wonderful. But what about the clinic down the street that doesn't have access? That's not, I think that's where the NHS might have some strength in that, to be able to do things more equitably sometimes than what we can do in the US. A lot of what we do is based on legislation. So I will say that's probably been a good tool for us, is what has come from the Office of the National Coordinator from Health and Human Services. Like, everyone has had to adapt to those, but we had a period of probably about 5, 7, 10 years where we got used to some of the, we developed evidence around these tools. But I do think you have to offer it to everyone. You have to provide enough support for your burnt out healthcare workforce. I mean, those things are very practical. You can't just throw things at people and expect them to adapt. It has to be a little bit of a partnership around that. And then you have to recognize that there is just so much inequity. And so you can't just put those tools out there and expect everybody to be able to use them. And I've had a long learning journey on that myself personally, which is how we got to this Health Tech Navigator program, which I've asked for 6 years. So, those are some of the initial thoughts that I have based on that question.
Perfect. Thank you, Anshu. And Amir, I'm going to come to you next.
Okay, so interestingly, we're in the middle of a pandemic that we've mentioned, and we've seen that there was a challenge around creating the vaccine and then getting the vaccine out there to the population. Of course, we haven't cracked it, but there was clearly a concern about inequity of access to the vaccine. In the UK, it became very apparent to the government and to the senior leadership in the NHS that if we were going to try and protect the NHS and the staff, then it was going to become really important, alongside wearing face masks and washing your hands and keeping social distancing and taking vitamin D. So I'm just mentioning those things are just as important as taking the vaccine. But that wasn't just left as we're going to put a few billboards up, or we're going to do a webinar on a Wednesday afternoon to leave people to decide whether they want to take the vaccine or not. There was a whole program set up. It was right from the very top. It was a very clear decision by NHS England that we need to do this. The medical director was diverted into coming on television every week to talk about the importance of the vaccination program, alongside many, many senior leaders, both within the political world as well as the medical world, talking about the importance of this. We had investments going in, not just to pay for the vaccines, but also in terms of the delivery. Every area had to set up a method of being able to roll this out. When the Pfizer vaccine came out, it was apparent that the Pfizer vaccine needed to be used within 2 days, and they could have up to 1,000 people. So you had to line 1,000 people up. Now, the reason I mention all this is, guess what? The NHS has just taught us how to reach out to millions of people and how to build the programs. Imagine, instead of saying you need to turn up for a vaccine, and we've seen again in the States and around the world where people have been turning up to establishments in their cars waiting to get their vaccine. How about we all get those very same people to sit in the car, to drive to a drive-through, and instead of getting a vaccine, they're invited to get access to their records. We confirm who they are, which the vaccine program did. We give them their PIN numbers, we help them how to do it, and drive out again. If we build the program, but we think about the investment that's needed at the start, so that at the end of it, we have a population of people that are not experiencing what I call industrial age medicine, which is come to a factory, come to a hospital, come to a GP surgery, and the doctor will see you, towards people actually understanding their healthcare needs. Remember that the average diabetic patient only spends about 3 hours in front of a healthcare professional. The other 7,997 hours, they're home alone at their own, but they've got access to the internet, they've got access to information, they can read what their doctor and nurse has said. And so I feel really passionately and really positive about the future as I see all these people that are online thinking, gosh, if we can do this, what else can we do to help people to help themselves? But we need that funding, because just with the vaccine program, if it had been left to a couple of webinars and maybe an odd poster here and there, hardly anyone would have had the vaccination. That's why for 16 years, we are where we are at the moment. People have got the devices, they've got the internet, they've got the broadband. What we now need is a change in the senior leadership and the culture. I think the request for patients to be able to view their records from the 1st of December is an indication that even the senior leadership now wants to do it. It's just that they haven't put the money in to make it happen. Well, it's not good enough to just say we want people to view their records or to just switch it on. We have got to do it safely. And that's why, although the program is currently being paused, I'm hoping that we can look at what we need to do and learn from the lessons around the vaccine program and start to say, how can we get from 12% of the population who've just got coded data, they can't even see what their doctor or nurse has written, to 90%. It's that gap, but that needs funding and that needs support and that needs programs. And I'm hoping people that are listening to this are thinking about how they can create those change programs and actually ask for the funding to make that happen. Otherwise, we'll still be at 12% 5 years from now.
Yeah, definitely. Christine, did you want to come in on that?
Yeah, building on all what Anand said, I think we also need multidisciplinary approaches. And I really would love that the medical sector would reach out and collaborate also with community workers and social workers who are in facilities outside the clinics and hospitals, exactly what you're highlighting, Amir, because it's so short time that you are in touch with them, but what happens with all the other choices they have to do in their part of daily life. So we need more dialogue across sectors to really bridge these gaps that we have identified today. And then I try to be hopeful like you are, Amir, and that the glass is half full. But when I speak to politicians, I would always say the glass is half empty, because we do need more focus, more resources to fine tune all our approaches. I think we actually know what to do, but we need to implement it at a system level. And that means that management also has to have an understanding that this is not about Excel sheets. This is about human lives. Thanks.
Thank you, Christine. I'll come to you, Ray.
Just about the system level. I think one of the areas that we really need to get improvement is between the systems. So in the UK, we've got a number of these you might call sort of GP triage type systems, Engage Consult, eConsult, and so on, and they're very, very clunky. I mean, you go into them and you're at square one every time you go in. They should be able. That should be a link with your medical record. When you start answering the questions why you want to see your GP this time, rather than just starting afresh every time, you should be able to link it back to the last time you saw the GP and to your medical record. So the NHS, I'm not sure who, NHS England, NHS Direct, X, whichever one of those bodies needs to get these system providers to have a proper communication between the systems. Another thing is on GP websites, for example. We did a bit of work looking at different GP websites and being able to find stuff on the GP websites. And a lot of GP websites are really poor. They're very poor. And you question, well, why does, we looked at accessibility using some standard guidelines on accessibility. These were GP websites in Cornwall, and hardly any website met those accessibility levels. So we've got to up the game in terms of some of the digital tools that we're providing and make sure that the right people are doing it. I'm not sure that, it probably needs to be done at a reasonable scale for it to work quite well.
Thank you, Ray, and thank you all so much. This has been such an amazing discussion and so many great comments and resources shared in the chat. So I just wanted to bring us to a close here, but I wanted to give you all a kind of final word or what next, if we can do that quickly in a quick roundup. So Anshul, I'll come to you first for your final thoughts.
Yeah, I think my takeaway is that, a systematic approach, like taking these best practices that we're seeing in some of your practices and really a systematic approach, and then supporting clinicians and patients to be able to really use these digital tools. It's very powerful. Patients expect it, and our community members expect it in every other part of their life. Doesn't make sense that healthcare is so far behind. So I think it has to be very thoughtful, but it's important to kind of move forward. for patients to truly engage with their health and health information.
Amazing, thank you. Christine, I'll come to you next.
Thank you very much. I would end as I started by raising the fact that many people are actually not capable of using the information that we provide to them. So we need to make a better fit, providing what they need. So it means really looking at our services, looking at the patient journeys, whether it's digital or face-to-face, and see where we can do better. And where we can start is really with the irritations and then turn them into innovations. Because if there is something annoying or if there are any barriers and we identify, then we should change to make it better and not just document it and then lean on. So let's make it fit much better than we do today. Thanks.
Thanks, Christine. Ray, I'll come to you.
I think we just need to re-pursue the navigator or the digital health champion role much more, and the obvious place to start with that is in sort of further education and the undergraduate curriculum. So all our nursing students, health professional students, medical students across the country should have some sort of role where they go out and they come to Amir's practice or other practice, and they sit with 100 patients and talk them through, help that role of being that sort of communicator navigator role. And it should be something that we should be doing across the country.
Thank you, Ray. And finally, Amir.
So whilst these series of webinars have really been about patient access to records, I see this as two sides of the same coin. As you said, I'm chair of the Association of Greater Manchester Local Medical Committees, and that's more about the medical side of things. We also need to spare a thought about how we share information with organisations and between organisations. At the moment, as things are, if an organisation wants to look at your record, you have to ask the patient if it's okay for them to look at it. I've not seen my own record, so I don't know what errors, mistakes, things that are missing in there are there. So it's very hard for me to know how I would answer that question if I was asked for it. So what I'd really like to see is that patients are given the opportunity and given every opportunity they can to be able to view their records, check for errors and mistakes and things that are missing, make sure that it's as correct as it can be because it's in your interest to do so. But then when that patient then presents to a casualty, to an out of hours, travels to another part of the UK or travels abroad, and well, inside the UK, because it's the NHS we're talking about at the moment, then when they're asked by whoever it is, can they look at their records, they're coming from an informed decision. However, there will be some groups of people who can't do that. And I mentioned things like patients with dementia, where we need to do it in their best interest. And I call this responsible sharing. We really want to encourage as many people that can go online to do so. But also, let's not forget that organizations also need that data as well. So let's start talking about how we can safely and responsibly share information. I've sent some information about that. And so let's widen it. It's not just about the patients, it's about the wider organizations as well.
Thank you, Amir, and a huge thank you to all of you, all of our speakers, for this really, really fruitful and interesting discussion this afternoon or this evening or this morning, wherever you are in the world. I think we've covered a huge number of the topics here and a huge number of the issues that are attached to this. So it's been really great, and I've really enjoyed the discussion. So thank you all so much for joining us. If anybody's keen to keep the conversation going, please do use our hashtag BMJ Records Access. We will still be on social media and we'd love to keep the conversation going about this. If you weren't able to join our first two webinars, you can watch those over on our BMJ YouTube channel, where this webinar will also be posted up probably tomorrow evening. So you'll be able to watch them back if you've enjoyed the discussion or would like to share with any of your friends, colleagues, neighbours, or anybody else who will listen. Please join us next week for our final webinar in the series, where we're going to be exploring the governance and bureaucratic challenges of patient access to their records. I'll be handing back to Henry Schoolcroft, who's my fellow patient editor and fellow co-host for next week. You can sign up for that webinar on our patient editor Twitter account and also on bmj.com. So thank you all so much, everybody. It's been great to have you all, and we hope to see you again next week.
Thanks very much, everyone. Thank you.
Thanks, everyone.